today I'm going to be presenting on the Medicare Promoting Interoperability Program for hospitals. So first I'm going to provide a brief review of the history of the program. I'm going to cover the Stage 3 requirements for 2021. Then I'll spend some time on the most recently released IPPS rule and finish up by touching on a few action items. So to appreciate where we're at today, I thought we would take a little trip down memory lane to review the history of the program, just kind of as a reminder of how far we've come, really. So the American Recovery and Reinvestment Act of 2009 mandated that Medicare and Medicaid must incentivize providers and hospitals to adopt, implement, and upgrade certified EHR technology, or CERT. I'll be saying that word a lot over the next 20 minutes or so, but it's Certified Electronic Health Record Technology. And then demonstrate meaningful use of that health IT. So in response, the EHR incentive program was created, and that started back in 2010 was when it was first introduced. And CMS initially implemented this program in progressively more difficult stages. So stage 1 began in 2011, and that really focused in on the implementations of EHRs. It established requirements for the electronic capture of clinical data, including providing patients with electronic copies of their health information. Stage 2 advanced the use of EHRs in 2014 and encouraged the use of CERT for exchanging information. And then with modified Stage 2 in 2015, that really aimed to ease the transition into Stage 3 requirements. And Stage 3 began in 2017 on a voluntary basis, and the focus there was really to improve health outcomes using CERT. So at a basic level, the EHR incentive program allowed hospitals to earn incentives for EHR adoption and use. Hospitals were eligible for Medicare incentive payments for 4 years and Kentucky Medicaid incentive payments for 3 years. And those incentives continued through 2016 for most hospitals, depending on when they started in the program. And although the incentive phase for hospitals ended, hospitals must continue to participate in this program each year in order to avoid Medicare financial adjustments. Hospitals that don't satisfy the requirements are subject to those Medicaid penalties, and those began back in 2015. And remember, unlike other programs, the Medicare EHR incentive program, or now the Medicare PI program for hospitals, has no defined end date. So in 2018, CMS issued some major updates to the program in the 2019 IPPS rule. And as a reminder, or for those who maybe aren't as familiar, this is how CMS implements updates to this program on an annual basis through the Inpatient Prospective Payment System rules. So in this one, CMS overhauled the program to focus on improving flexibility, relieving burden, and placing emphasis on measures that require the electronic exchange of health information between providers and patients. They refreshed the measures, rebranded the program, and reconfigured the program scoring. CMS finalized new Stage 3 measures, they made changes to others, and they removed certain measures that didn't emphasize electronic exchange of information. They said they overhauled the program in order to better achieve their new program goals, and renaming the EHR incentive program to the Promoting Interoperability Program was one of those changes. CMS said the former name no longer adequately reflected the status of the program because the incentive phase really ended long ago. This was also when CMS introduced the new performance-based scoring methodology, and that moved us away from the previous all-or-nothing threshold-based scoring that was previously used. They said this change was aimed at providing a more flexible, less burdensome structure that would really allow hospitals to put their focus back on patients. And performance-based scoring encourages hospitals to push themselves on measures based on how they deliver care to patients, instead of just increasing thresholds year after year on measures that may not be as applicable to each individual hospital. Okay, so that brings us up to speed with how we got here. Now let's go ahead and take a look at this year's requirements for program year 2021. Unlike all of the changes included in the 2019 program overhaul, last year, 2020, when CMS published the 2021 IPPS rule, they said that in recognition of the significant impact of the COVID-19 public health emergency and the limited capacity of healthcare providers to review and provide comment on extensive proposals, they limited their rulemaking just to focus on essential policies. So as a result, they made minimal changes to program year 2021 requirements, stating that their purpose was really just to provide an increased level of stability within the program in reducing burden on hospitals. So for reference, I've included the links to the fact sheets and the full rulings on this slide, but we'll go ahead and take a look at those specifics. So in 2021, the reporting period is a minimum of any continuous 90-day period. Hospitals must also submit 2 self-selected calendar quarters of data for 4 clinical quality measures. CMS requires hospitals to use the existing 2015 edition Cures update or a combination of the 2 for the full reporting period. CMS will continue to implement that same performance-based scoring that we used last year, so hospitals must earn a minimum of 50 points. And then lastly, the attestation deadline for 2021 has already been extended. It was originally supposed to be the end of February, and back in October, they went ahead and already extended it, so hospitals will now have until the end of March to submit their attestations. So for 2021, hospitals are required to report on these 4 objectives: electronic prescribing, so generating and transmitting permissible discharge prescriptions electronically. The query of PDMP bonus measure is also included and optional again in 2021. Health information exchange. This objective really encourages and leverages interoperability and promotes health IT-based care coordination. There are 2 measures: the support electronic referral loops by sending health information and the support electronic referral loops by receiving and reconciling health information. Provider to patient access, this gives patients electronic access to their health information. And then lastly, the public health and clinical data exchange objective. And taking a closer look at this one, for 2021, hospitals must be in active engagement for any 2 measures of their choice. And most Kentucky hospitals have been meeting these public health measures through KHI, the Kentucky Health Information Exchange, and will be able to continue doing so. And before I move on from this one, as a reminder, active engagement means that the hospital is sending production data or in the process of moving towards sending production data. And there are 3 options that satisfy the requirement. So option 1 is completed registration, and this means that the hospital has registered to submit data, so you've got your signed participation agreements and addendums on file with KHI. Option 2, the hospital's in the process of submitting data via testing and validation. And then 3, that's when you're officially live and electronically submitting production data. So if you have any questions about your hospital's level of public health reporting status, I recommend that you just reach out to your KHI outreach coordinator. And I think Andrew pointed out earlier, they are here today. So Anne, Teresa, and Tiffany were back here at the table. So maybe grab one of them before you leave today to check on your status. Okay, moving on to clinical quality measures. So in order to successfully participate in the Promoting Interoperability program, CMS requires that hospitals also submit clinical quality measures. And there are no performance thresholds to meet, but the CQM data that you submit must be reported exactly as generated by your hospital's CERT. This year, hospitals must submit 4 electronic CQMs for 2 self-selected calendar quarters of data via the QualityNet Secure portal and using any combination of QRDA1 Category 1 files, 0 denominator declarations, or case threshold exemptions. And reporting CQMs manually is no longer an option except in specific circumstances where electronic reporting isn't feasible. And also, I'll just note that electronic submission also fulfills the inpatient quality reporting requirements as well. Okay, this is the measure set. Last year, CMS reduced it from 16 down to 8, but they did add a new one, and that's the safe use of opioids, CQM. And that really seeks to reduce preventable mortality and the costs associated with adverse events. Taking a look ahead at CQMs, there are a few things we already know as they were finalized last year, and that is that CMS is progressively increasing the number of quarters for which hospitals are required to report CQMs. So from last year in 2020, hospitals only had to submit 1 quarter of data. This year, as I said, 2 quarters, and then 3 in 2022, 4 quarters in 2023. So in alignment with the inpatient quality reporting program, CMS really believes that increasing the number of quarters for which hospitals are required to report will produce more comprehensive and reliable data. Also, one last thing before we move on from CQMs, just keep in mind that last year CMS also finalized that they will begin publicly reporting CQM performance data on the Hospital Compare website for the first time beginning with this 2021 data. So just keep that in mind. This data could be made available to the public as early as the fall of 2022. Okay, moving on to scoring now. So similar to last year, this is an example of what the stage 3 scoring is going to look like. You take your performance rate, which is your numerator, divided by your denominator, and then multiply that by the measure weight. The scores of each of the individual measures are then added together to calculate the final promoting interoperability score. And it is capped at 100 possible points for each hospital. A total score of 50 points or more satisfies the requirements in order to avoid a Medicare payment reduction. And let's go ahead and talk about those payment adjustments for just a moment. The legally mandated penalties under high-tech do continue to remain in effect, and truly that's why success in this program is so important. Like I said earlier, all hospitals must continue to successfully attest each and every year. If not, the eligible hospital payment adjustment is applied as a reduction to the IPPS payment rate, and then the critical access hospital payment adjustment is applied to the Medicare reimbursement for inpatient services during the cost reporting period, so the year in which the hospital fails to meet the requirements. Okay, so we reminisced about the history of the program. We reviewed the current requirements for this program year. I want to go ahead now and just take a brief look at the future of the program. So we'll just take a peek at what CMS finalized in their most recent IPPS rule. And unfortunately, unlike last year, this ruling does include significant updates to the measures. CMS said that they prioritize several important policy goals to promote EHR safety, increase the exchange and availability of data, and really continue to align across programs. So the biggest changes for 2022 impact PI measures. They also finalized several proposals to update CERT requirements and CQM policies, and those take effect in 2023 and 2024. And again, I've included the links on this slide just so you have them for future reference if you want to go back and take a look at them. Specifically, CMS finalized to maintain another 90-day reporting period in 2023, but looking ahead, they did already finalize a 180-day reporting period in 2024, so that's a big one. They said that they were going to keep the 90-day reporting period for 2023 because as I said earlier, you're going to have that 2015 edition Cures update in place, so that's going to give you a little bit of extra time and flexibility for that. And they said that by going ahead now and letting folks know about the increase in the reporting period for 2024, that gives you 2 years to plan ahead. We'll go ahead and jump ahead to the additions. So as the COVID-19 pandemic further highlighted the need for data exchange across state lines to support testing and treatment and vaccination efforts, CMS finalized adding several updates to further advance data exchange. So, for example, this new bidirectional exchange measure that was added to the HIE objective as an optional measure to the 2 existing measures. and this is going to be available beginning in 2022. And CMS did say that they understand not all hospitals will be able to report this measure, so that's why they made it an alternative to the two existing measures. We need to be there. Okay. Next, CMS added to the Protect Patient Health Information requirements. So hospitals must attest to having completed an annual assessment of SAFER guides, and that's all new beginning in 2022. The SAFER guides really aim to prepare hospitals for events that may lead to EHR unavailability and safety risks such as disruption or natural disasters. And CMS has clarified since this ruling came out that it is going to be optional and not optional, it's going to be mandatory in 2022, but basically they're not going to score it. Okay, for 2022, the ruling didn't change the CQM measure set. There will still be 9 available for reporting, but in 2023, they did adopt 2 new measures and then removed 3 already for 2024. Beginning in 2022, so not this year's attestation, but next, you won't have to attest to attestation statements 2 and 3. But starting in 2022, hospitals will begin having to earn a score of at least 60 points instead of the current 50-point threshold to avoid the penalty. And basically, they said that given the widespread program success of hospitals in recent years, they believe that those results signify raising this minimum point threshold. So if we look back at data from 2019 attestations, it shows that almost 99% of all participating hospitals scored above that 50% minimum threshold. So they were okay with increasing the standard. And really, CMS wants to encourage higher levels of program performance. A couple more things. So I just want to point out there were a few things that CMS did not finalize. That was removing their the stroke 3 CQM. Also, they did not finalize their proposal to modify the patient electronic access to their health information measure. That proposal really tried to establish a new data availability requirement, but CMS agreed with commenters that this modification needed additional clarifications. So in case you ever wonder if, during that comment period, if your submission and your feedback matters, it really does. So they listened on that one. Okay, so that wraps up the look into the future with the IPPS rule. I'm going to cover just a few action items to reset our focus on this program year. So this slide provides a really good summary of program year 2021 requirements. Again, Medicare eligible hospitals and critical access hospitals must attest through the QualityNet secure portal. Usually those attestation screens open up during the first week of January, and then as I reviewed, that deadline extension gives us until the end of March to actually submit the attestation. This, again, participation checklist is just another good resource that I think summarizes the program. For 2021, hospitals are required to report on all of the PI objectives and measures for a minimum of a 90-day period, using 2015 edition SART, reporting on 4 ECQMs, and conducting a security risk analysis. I know it's really hard to believe that we only have a few weeks left in this calendar year. So to finish 2021 strong, you need to be running those PI reports as often as possible. If you're a Kentucky REC client hospital, you can send them to us for review as often as possible. We have some hospitals that send reports on a weekly basis, others monthly. We plug that data into our stage 3 gap analysis tool, and that really gives us a good visual of where your hospital stands in the program, and we're able to estimate your potential score as well. So historically, we've completed on-site visits and in-person meetings, but of course, with the pandemic, we've all stayed out of the hospitals. So we've had a lot of virtual meetings and conference calls, and we're going to continue to do that. We also still plan to screen share during attestations to make sure everything gets submitted correctly. I've included this slide just for you to reference later. It has some CMS links to 2021 resources. And with that, I thank you all for your attention today. If you have any questions, comments, concerns, please come find me afterwards before you leave today, and I'd be happy to help. Or here's my contact information. You can always call or email anytime. And I think I have just a couple of minutes, so before I hand it over to Robin, I just want to take a minute to recognize some of our Kentucky REC client hospitals. I'm pretty confident that they could have given this presentation today. So I know several are joining us virtually, and a couple of are here in person. So we just want to say thank you for all of your hard work, especially during this very challenging year. So really quickly, thank you, ARH. And then a few online virtually. Just want to give you a shout out. Crittenden Community Hospital, Livingston, Marshall, Monroe County Medical Center, Owensboro Health Muhlenberg Community, and Russell County Hospital. We're looking forward to seeing you all very soon. So with that, I'm going to turn it over to Robin, and she is our last presenter of the day, and she is going to teach us all about telehealth.